Thank you. I have the great honor to introduce to you Douglas Brooks, the Director of the Office of National AIDS Policy. He is the President's lead advisor on domestic HIV/AIDS and is responsible for overseeing implementation of the National HIV/AIDS strategy and guiding the administration's HIV/AIDS policies across federal agencies. He previously directly managed and oversaw the management of federally funded projects, including Ryan White programs for adolescents, CDC prevention for African American Black youth, and a HRSA and HOPWA special project of national significance. Mr. Brooks has a Master of Social Work from Boston University and is a licensed clinical social worker in Massachusetts. And a point of personal privilege, working in Washington, I have the opportunity to hear Douglas speak on a number of occasions, and he faithfully talks about the importance of housing. So please join me in welcoming Douglas Brooks.
Thank you, Nancy. Good morning. I'm actually very happy to be here. And I want to thank Nancy and Steve and the organizers for inviting me, and thank all of you for being here and for the work that you do. I also want to, similar to Nancy, point of privilege, I think it's well known that Nancy is going to soon be taking a much-deserved break, and when you go to work at the White House, they spend the first several days drilling into you the importance of not abusing the power of your position. So I'm not going to abuse the power of my position, but I am going to ask you all to stand and join me in thanking Nancy Bernstein for her hard work. Oh, you're trying to photograph? Thank you for your leadership, Nancy. I'm hoping today my plan is to, I didn't know who was going to be in the room. I knew some researchers and I assumed practitioners and people living with HIV, advocates, and hopefully a few activists as well. And I thought I would use my time to provide you an overview of where we are and what we're thinking at the Office of National AIDS Policy. I'm hoping that will be helpful in your deliberations today. And I'll tell you that one of the things that we're really looking for and hoping that we will hear from you are some best practices of service integration, health, housing, primary care, a range of social services are being integrated. So I'll give a start here. And I'm just looking at this table here and want to give out a shout to Dan Wolfiler and Greg Millett, two folks who have been doing the work for a really, really long time and are people who have been folks who I really greatly appreciate. So, hi. I bring you greetings from President Obama. I think it is unquestionable that our president has shown his commitment to HIV, to people living with HIV, to people affected by HIV. He certainly has expended a lot of his effort and energy on ensuring that we have affordable health care, and while it may not be as widely appreciated, really spends a lot of time and directs the senior staff and those of us working for him to be thinking about and creating plans for ending homelessness. So putting HIV housing in the context of as John just said before, just wanting all people to have a safe, affordable place to live is something that is a priority for the president. You likely know that in 2010, we released the National HIV/AIDS Strategy with a vision that the United States will become a place where new infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, would have unfettered access to high-quality, life-extending care free from stigma and discrimination. I love that vision, and I think I do think it's achievable. And to move us toward that, the strategy laid out 4 goals, 3 of which were health-related: to reduce new HIV infections, to increase access to care, improve health outcomes for people living with HIV, and to reduce HIV-related disparities, health disparities. I intentionally put the last one in a larger font and bolded because it's my job, and that is to ensure that we're achieving a more coordinated national response to the HIV epidemic. The strategy, I had taken this slide out when I first, I've been on the job 7 months, it will actually be 7 months Thursday, I think. I'd taken this slide out for a while, but I put it back in because there are questions and conversations about the strategy and what next, and I'll say a little more about that. But I just want to highlight that there were a limited number of action steps. It set 5-year quantitative targets. There was an emphasis on evidence-based approaches, and it charged multiple agencies with implementing the strategy, agencies across the federal government. We saw it also as a roadmap for all public and private stakeholders responding to the domestic epidemic, something in which everyone could engage, and focusing on improving coordination and efficiency across and within the federal, state, local, and tribal governments. The emphasis is on concentrating efforts where HIV is most concentrated in populations with the greatest disparities, including gay men, people of color, and transgender women. So you know that in the United States of America, there are about 1.1 million people living with HIV, and only about 25% are virally suppressed. So and I'll just say this is a slide we developed internally, because the latest one from CDC shows it being 82%, and we actually know that about 84% of people living with HIV have been diagnosed, 66% linked to care. We lose quite a few people, and we only have 37% of those people retained in care, and I think this is really cogent for our housing conversation. And 33% have been prescribed ART, and as I said, about a quarter are virally suppressed. So in December of last year, we added a piece to the strategy, and I say that's my language. We talk about the HIV care continuum. I see it as being an extension of the strategy, and if you notice that the cover, it's where it comes under the strategy. It was created by a presidential executive order in 2010, and Greg will tell you that there are varying levels of how things are created and how the president issues his directives. And an executive order is a very powerful document, and the fact that the president issued this was yet again a demonstration of the importance of it to him and to the administration. It responds to scientific advances since the strategy's release 3 years earlier, and promotes expansion of successful testing and service delivery models, encourages innovative approaches, really helps us to think about how to appropriately focus the resources on interventions that improve outcomes along the care continuum, and is overseen by a joint federal working group, our office and the Office of HIV, AIDS, and Infectious Disease Policy at HHS. It charged folks with, I'm starting to move through this, just reviewing what was, what is, and identifying ways to improve outcomes and to recommend ways to integrate efforts. And once again, really thinking about how to align the resources. It was very timely in that, as many of you know, we have pardon me, had just had some pretty significant scientific advances. Knowing that treatment is prevention and that folks on treatment who are virally suppressed can reduce transmission to their partners by 96%. That earlier treatment prevents long-term complications. Testing is faster and more accurate than ever before, and we have some pretty standard testing guidelines. The recommendations of the working group, so the feds came together, put together 5 recommendations along the care continuum, was to support, implement, and assess, thank you, innovative models to more effectively deliver care along the care continuum. Thanks. Tackle misconceptions, stigma, and discrimination. Strengthen data collection, coordination, and the use of data to improve health outcomes. To prioritize and promote research to fill the gaps in knowledge along the care continuum, and then to provide information, resources, and TA to strengthen the delivery system along the continuum, particularly at the state and local levels. I'll just keep on the way it's doing. In the care continuum, there are many targets. Target 6 speaks directly to housing in that it sets a target of increasing the number of Ryan White program clients with permanent housing to 86%. We know that being stably housed is an important precursor to getting people into regular care. Homeless or marginally housed people living with HIV are more likely to delay or have poorer access to care and are less likely to receive and adhere to optimal antiretroviral therapy. In the report that we will put out, you'll see that there has been some increase. I think, you know, it's important to tie all of this together as we're thinking about service integration. And as I said earlier, the Affordable Care Act has provided tremendous opportunities for people living with HIV to get covered, to have affordable insurance plans, and it also has increased resources to community health centers. We are aware of things that we have to keep moving and some regs that we need to consider, but I hope that you will all agree the Affordable Care Act is a pretty amazing thing for this country. Thanks. We have some ongoing strategy implementation needs, including my job of ensuring that we're continuing to be collaborative across governments and with our private partners. Focusing on geographic and demographic hotspots with people with the greatest HIV burden, gay and bisexual men, transgender women, Blacks and Latinos, and you know, and I will say, while we see the greatest burdens here on the largest scale, we also know that there are places and people where there also continue to be, and we have to be careful to pay attention to disparities that exist among Asian Pacific Islanders, among Native Americans, and so we try to be focused on it all. Maximizing outcomes along the continuum of care is something you're just going to hear me say a lot. Our focus on primary prevention is also extremely important. While the people who are living with HIV and improving outcomes along the care continuum is essential for ending the virus or greatly reducing the virus, we also don't want to forget that we don't want people to get this virus, and that we need to be really focused on primary prevention efforts that are evidence-based and that really work. So it's something that we continue to be quite committed to. I think it's important for us to provide technical assistance to the HIV workforce for the ongoing changes in the environment. it is, as much as I love my job and I love coming out, speaking to people and being engaged, you know, sometimes I feel like I'm the guy whose role also is to say, in case you didn't know it, things really are changing. The system is changing. It's changing. We're not stopping it. It's not going to halt. You know, there are some who think a new election may make a difference. I'm hard pressed to see how we are going to undo giving millions of people insurance, and how we're going to undo moving forward in things. Moving forward in service integration in a way that is important. And so that means that those of us who, similar to what the mayor talked about earlier, those of us who were there really early on helping build these systems of housing and care have to be thoughtful about how to integrate them into existing systems and structures that are going to be sustainable. And I think John made a terrific point too, is part of what we should be thinking about is how we end all disparities, and how we think about safe and affordable housing and care for all people. One of the things that I'm really working closely with my CDC colleagues on is understanding how we can get a more rapid analysis of the surveillance data and the use of that data for public health purposes. Dr. Eugene McCrae is now overseeing the Division of HIV AIDS Prevention at CDC, and is someone who's really committed to that. We talk about it regularly, and he really is quite hopeful and believes that we can do this better, equally as efficient, and faster. So I know that because I've been running programs and and trying to figure out, well, how do we move things forward, and we're still using data from 3-4 years behind. So definitely committed to that. We have set some priorities and have submitted them to the Chief of Staff's office, and they include further implementing the HIV care continuum. I think it's important for us to find that 16% of people who are living with HIV who don't know their status. In the world of, and call me Pollyannish or idealistic or whatever, but in the world of apps and smartphones and various ways of interacting with people, I'm hard pressed to believe that we can't find the 16% of people, approximately 183,000 folks, who are living with HIV but not yet diagnosed. I am not fooled into thinking that some of these people, probably most, are those we call hard to find, difficult. I think many are probably people who are homeless, people who are precariously housed, people who are suffering mental health, substance use disorders, and so it will require a thoughtful, intentional, compassionate approach, and it's something I want us to do. And so we also need to locate and return and retain into care 29% of the people who have fallen out of care. I think we need to identify the role of housing in this. We don't know, but I imagine like 99% of you might suspect that the precariously housed and people who are living on the streets may be some of the folks who then don't find themselves able to get back to a doctor's appointment or able to remain in care. We, as I think I mentioned, the quantitative targets for the National HIV/AIDS Strategy expire next year in 2015, so we have to update those targets. We will have robust conversations, and I hope not acrimonious, but folks are already approaching me. What are we going to do? What's strategy 2.0? What's the next strategy going to look like? And what I say is we have 26 months left in this administration. We can spend a year of our 26 months redoing and going through a process and figuring out the process and processing the process around the process, or we can update the targets, make tweaks where we need to make them, because I don't say that there aren't places where we could make some tweaks, and get the work done. While we know we have a supportive president and a supportive administration, and we can leave a blueprint for whoever comes behind us, and hope that things will be in motion in the federal government that can get done. We have to continue to stay focused on ensuring Ryan White and the Affordable Care Act are well coordinated. I don't know if this slide's in here, so I'll say it here. Our administration, the president, has shown his commitment to Ryan White. The fiscal year 15 budget demonstrated the commitment, and that remains. I think we'll begin the SY16 budget process. We've begun it, and see what. But the folks at the health team and the folks with whom I work all feel like we don't know the benefits of the Affordable Care Act, don't know them well enough to make any changes to the Ryan White Care Act. And so we believe, and it sounds like many on the Hill also believe, that this is something we need to keep in place. Aligning the federal resources with epidemiological data, which is a lovely phrase. It's a whole lot easier said than done. We've begun to do some of it. Some of you, I'm sure, are aware. The CDC certainly has made some changes and moved dollars into the southern U.S. where they needed to be and to do the work, and with specific populations. At the same time, we have to be very thoughtful. Dr. Fauci reminds us that HIV is not static, that it's dynamic, and what we don't want to do is shift funds rapidly and without great thought, and then see these epidemics rising in places where we've been very successful in lowering them. So we have to be really thoughtful about that, and we are engaging some very thoughtful people, and I certainly want to hear your thoughts as well. Developing public and private partnerships, public-private partnerships that augment our federal efforts. It's been very exciting to be in the position and having private funders come to us to ask how they can support the work that we're doing, and there are various ways in which I think people can do, from putting actual dollars into the work, but I think there are also opportunities for organizations that are focused on homelessness, organizations that are focused on care, to also help us think about how to move forward. This next priority, on the surface, may not seem to be completely relevant to housing. I think it's extraordinarily relevant, in that looking at ways to explore employment and employment services that create opportunities for people living with HIV to get back to work, or in some cases for people to become employed for the first time. At the Department of Education and the Rehabilitative Services Division, there is a program that is designed to help people who have been on disability, including HIV, to get back to work, and to provide supportive services for people, to provide stipends in some cases, and to think about how to move themselves from those who are ready and capable and desirous, to move from being on health, being on Social Security disability, and getting back to work. And so we are engaged with the National Positive Working Coalition, a group of HIV positive advocates and leaders, and with the Presidential Advisory AIDS Council on this effort, and thinking about how we move it forward. And I think, when people feel confident and are able to get back to work and have benefits and can move themselves into other housing, that provides an opportunity for us that we haven't had. They're telling me my time is up, and I didn't realize I was talking so much. So I'll say this around the employment and the housing piece. I do hope that we'll be very thoughtful together on this. I think it's a real opportunity. The models that we designed it, and I say we because I was there. The models we designed were for people who were dying, and so there was sadly an inherent turnover. And so housing was created, more housing opportunities were created because people were dying. Gratefully, that's not the case now. And so we have to be thoughtful about transitional housing and how we move people along. We're focused on developing interventions that address the intersection of HIV/AIDS, violence against women and girls, and gender-related health disparities. I'll draw your attention to whitehouse.gov, where we released a report on that just last week or the week before. Please take a look at it. My colleague, Dr. Maggie Chornogorski, led the effort of putting that report together, and the work that's happening across the federal government on it is quite impressive. We're focused on reducing HIV disparities in the southern U.S. and among gay and bisexual men, with attention on young black, gay, same-gender loving men, where we see just untenable disparities. Greg and Amy are going to talk later, so I won't spend too much time. We put about $332 million and supporting about 52,000 economically vulnerable households with HIV. HOP will assist people who are without stable housing arrangements. And we really do believe it's a proven cost-saving strategy. It reduces emergency department visits and inpatient stays. We also are able to use funds under Ryan White for, excuse my little typo there, may be, used for referral services and assessment, search placement, and advocacy services, or short-term emergency housing defined as necessary to gain or maintain access to medical care. So, I would suggest that housing is integrated into the care continuum, into the work of the federal government, and we need to think about maybe how to enhance that. What are opportunities to maximize benefits through current programs and through other existing programs? I say this to all of you who I love so much. We do a lot of talking with each other. And really want to encourage us to have conversations with the homelessness people, with the housing first people. That's a very strong model that I think is worth thinking about wraparound prevention. What does that look like? So, just there. There we go. So, well. Well, we need to then be integrating that conversation with the folks who maybe have taken it over. So, so there are challenges along the continuum, including unstable housing, side effects, mental illness, and what do we got? Like a minute here. I'm going to take a couple more minutes. And as I said to you earlier, 54% of people living with who were serving in the HOPWA programs are 51 years or older. I mean, that's just a big change from what we saw. And most of the money is being spent on permanent supportive housing. About 90% of all our housing expenditures are on permanent housing versus transitional. I think there's an opportunity there too. With transgender and IDU clients, we were the people who were least likely to report stable housing. And so thinking about that. I'll mention the role of trauma and mental health and substance use disorders. I've mentioned those. I think as we are thinking about building robust housing service delivery system, those pieces have been included. I mean, there are many housing programs that include them. I think we need to look at how the inclusion improves the outcomes along the care continuum and helps us better integrate. The very last thing I'm going to say is last week when we delivered the report on the intersection of violence against women, HIV, and health-related gender disparities, one of the beautiful things was the Department of Justice and HUD have partnered to bring together. The Department of Justice is transferring about $1.4 million to HUD specifically to focus on housing for women who are victims of violence and sexual assault, women living with HIV, to ensure better long-term health outcomes. So I'm very excited both about this untraditional partnership and that effort. And then if you didn't see, once again, I would encourage you to take a look at the emphasis on, new emphasis on integrated housing and care between the Department of Labor and HUD that's happening as well. And some of that includes housing stability, but life skills, job readiness, and employment training. And that is being hosted on the HOPWA, on the HUD, maybe HOPWA, but on the HUD website. So take a look at that if you will. This last slide is just something that I keep mainly for myself, thinking about how we integrate trauma-informed care throughout primary care, but throughout all our services. And you know, it's real as a black gay man, as a person living with HIV, and when I think about the micro traumas that I have and do encounter, and I'm pretty, realized. And when you think about folks who, for any number of reasons, are already experiencing oppressions, how might including trauma-informed approaches make a huge difference in the work that we're doing? So that's what I have. I think we have some time for questions and answers. I've eaten into some of that, but sorry.